Good day. My name is Michelle Lavander. I'm the director of the USC Center for Health Journalism. Thanks for joining us today for our Health Matters webinar, Disappearing Options, Tracking the Story on Reproductive Health Care. Abortion policy has been all over the news lately, thanks to the dramatic turn of events at the top of the Democratic ticket. President Biden seemed reluctant to even say the word abortion, while Kamala Harris was the first vice president to visit a Planned Parenthood clinic. She has put reproductive rights front and center in her presidential campaign. Trump, meanwhile, has sought to distance himself from those in his party calling for a federal abortion ban. But even before this became a key issue in the high-stakes presidential election, it's been a head-spinning year for those tracking reproductive health care. Louisiana passed a bill to criminalize possession of abortion pills without a prescription. And Alabama Supreme Court ruled that embryos created through IVF are legally children, prompting new emergency legislation, but leaving a climate of confusion for clinics and families. And two separate Supreme Court cases threaten to impose further restrictions on abortion pills and women's access to reproductive care. Meanwhile, 21 states enacted new bans or restrictions on abortion, while many blue states moved to strengthen protections for abortion and reproductive care more broadly. This ongoing flood of news and shifting policy pose real challenges for journalists seeking to keep their audiences informed. Today, we're here to help with an expert panel deeply versed in these issues and strategies. They'll help us think through how to translate the latest developments into smart journalism at the regional and national level. Joining our panel today is Eleanor Klibanoff, the women's health reporter at the Texas Tribune. Her coverage on this beat has run the gamut from abortion and maternal health care to gender-based violence and LGBTQ issues. Previously, she was a journalist with the Kentucky Center for Investigative Reporting, where she reported, produced, and hosted the Peabody-nominated podcast Dig. Klibanoff has worked at public radio stations in Kentucky, Pennsylvania, and Missouri, as well as at NPR, and her stories have aired on All Things Considered, Morning Edition, and Here and Now. Shefali Luthra covers the intersection of gender and healthcare for the 19th. Her work has appeared in news outlets ranging from the Washington Post to NPR. Before joining the 19th, she was a correspondent for KFF Health News, where she covered national healthcare and policy. Her new book, Undue Burden, was published in May and shows the effects of the post-Roe world on pregnant Americans. Maya Manian is a law professor and faculty director of the Health Law and Policy Program at American University Washington College of Law. She's a nationally recognized expert on reproductive rights with a focus on access to reproductive health care. She publishes and speaks widely on abortion rights. Early in her career, she was a professor at the University of San Francisco School of Law and a litigation fellow at the Center for Reproductive Rights in New York. This webinar is made possible thanks to the generous support of the Commonwealth Fund and the California Endowment. We'll be archiving this conversation later today at centerforhealthjournalism.org. A word about our format today. We'll be hearing first from our speakers, and then we'll turn it over to the audience for questions. Feel free to share general comments in the chat. Because we have many people joining us on Zoom, we'll ask you to write your questions for our speakers into the Q&A panel. You can also write us there if you're experiencing technical problems. Now let's get underway. The Dobbs decision and other legal actions in court cases over the past year are dramatically changing the landscape of reproductive health. While this is often framed as a debate around abortion, a lot more is at stake. How is the ground shifting under us on a wide spectrum of reproductive rights, and how might we define what's at risk and what's imperiled in a historic moment? Maya, can we call on you to help us set the stage by explaining some of these recent developments in reproductive health care? And how do you explain these policy fault lines?
Sure, and thank you so much for having me. I'm thrilled to be part of this discussion. I think what we're seeing in this post-Roe public health policy landscape, we're really seeing come to life the reality that abortion cannot be segregated from the rest of reproductive healthcare and sort of targeted for restrictions without having all of these ripple effects on a wide range of healthcare, because abortion is deeply intertwined with a whole spectrum of healthcare issues, including things like prenatal care and pregnancy complications, such as for miscarriage management or ectopic pregnancies, with fertility care like access to IVF, with childbirth and maternal mortality rates, and we are seeing maternity care deserts that are increasing in states with abortion bans. So we're seeing all of these side effects on equitable access to health care more broadly than just for people actively seeking abortion care. Now, I say that, but I want to emphasize that that group of abortion seekers is also a very important group. And that is a group that is disproportionately low income and people of color due to widespread health disparities. So as we think about this whole spectrum of issues that is being impacted by the overturning of Roe versus Wade by the US Supreme Court, I think a useful framework, as opposed to thinking about it as just reproductive rights or just abortion rights, which is often how it's talked about in legal circles. For decades, advocates and academics have been talking about the reproductive justice framework. The reproductive justice framework was created by a group of Black women in the 1990s to address these long-standing reproductive health disparities and to recognize that it's not just about abortion rights on paper, it's about access to the full spectrum of care. And so reproductive justice is often framed as having three pillars, that it's about a human right to not be pregnant, to be able to become pregnant, and to have the right to become a parent and safely, and to raise your children in a safe environment. So of course, the right not to be pregnant includes access to contraception and to abortion, but it also means to be able to become pregnant, whether it's access to fertility care or not being subject to coerced sterilization, which we have a long history of in the US. And the right to parent safely includes the right to safe childbirth. And we've already had, even prior to the Dobbs decision, huge racial disparities in maternal morbidity and mortality and in the US, and we are expecting those to get worse in a post-Roe world. So I think in thinking about what's happening with abortion, we have to understand how it's interconnected with all of these issues, and the reproductive justice framework, I think, is an important way to sort of see that big picture. So I'll just set the stage there.
Great, thank you so much. Did anyone else want to add anything about this idea of this going far beyond abortion?
No, I'll just say that was a wonderful framework and sort of starting point. I often say, like, the story in Texas is no longer about abortion. I mean, of course, it absolutely is still about abortion in so many ways, but abortion is banned in Texas, right? I mean, legally, abortion is not happening, except in the rarest of cases. So much of what we're talking about has very little to do with that actual medical procedure and so much to do with everything that surrounds it, about maternal health and the deciding to have a child, to not have a child, to, safely parent that child. And so, this story was never just about abortion. It very briefly became hyper-focused on abortion, but I think now we're really in a moment where the conversation is much wider than abortion, or needs to be at least.
And Eleanor, just to kind of fill in some of the details to your point about abortion effectively not happening, you reported a story in June on how the Dobbs decision changed abortion access in Texas with some really dramatic numbers. So what did your reporting find?
Right. So before Dobbs and before SB 8, which was, the ban on abortions after about 6 weeks of pregnancy. So like the years before that, Texas was averaging about 55,000 abortions a year. Texas has 10% of the women of reproductive age in the country. It is larger than many countries. After Dobbs, in the 2 years since the Dobbs decision, when I wrote that story, Texas was averaging about 5 abortions a month. Which, what was fascinating about that story was how that number meant something so different depending on who you asked. There are definitely, anti-abortion advocacy groups who are basically saying, like, the law is working in that people are not getting abortions, but also in that, people who have medical complications, who have medical necessity, are able to get abortions, right? 5 abortions a month. We have not seen 5 doctors arrested a month. So clearly these laws are working. On the other side, of course, we're seeing, the just shock and outrage from the fact that, that leaves out, tens of thousands of women who otherwise would have sought abortions for a wide range of reasons, including, medical complications that they're not able to get abortions for. So the landscape is like unrecognizable from 2 years ago.
And Eleanor, just to follow up on that, it's easy for those in blue states to feel like, well, that's elsewhere. Those are those other people. and yet, what does the situation on the ground in Texas tell us about our future, even in blue states under a Trump-Vance presidency? And what storyline should we be thinking about in that regard?
Right. I mean, Texas, what happens in Texas, as they say, like, as goes Texas, so goes the country, so goes the world increasingly. I mean, I think there's the short term that we're already seeing, other states get backed up with, Texans flooding their state trying to get abortions, as well as people from other abortion ban states. But we're also seeing the ways that, so many of the problems that Texas's maternal health care system, including abortion, are lacking, are true in every state. I mean, there's no state in the country that is, doing enough to reduce disparities in maternal mortality. There's no state that's like really doing enough to support low-income families. So there's obviously many that are doing much more than Texas. But I think, the abortion bans could potentially go nationwide story is one storyline that reporters in blue states should be preparing for. Absolutely. And I think there's pretty good playbooks from states that have already banned abortion on like how to cover that, as sensitively and comprehensively as possible. But also, abortion is still allowed in your state. That doesn't mean your state is doing everything right on maternal health care. And that doesn't mean there's nothing to report on maternal health care.
And one thing I can add in there potentially, Michelle, is this is something that came up a lot in frankly trying to pitch a book about abortion, was how do you argue that this is a national story when bans are concentrated in a certain number of states? And it's exactly what Eleanor said. It is that states that are near places like Texas have backlogs. They have far longer wait times for not only abortion, but all the other health services that their clinics provide, whether that is birth control or pap smears or colposcopies or what have you. I think there's something to be said about the real intellectual leadership of the anti-abortion movement that comes from Texas. Names like Jonathan Mitchell, names like Kevin Roberts, these are people who come from Texas and are very big deals in the state, but whose intellectual frameworks for abortion restrictions are influencing policy in many other states and across the country. And it's worthy for journalists who care about these issues to know those names and know their work. And that means going to their work in Texas. But what I think is really interesting also is even before Roe was overturned, abortion access was not very robust, including in blue states. And that remains the case in a lot of blue states. Some have, put more money into supporting abortion providers, have talked a big game about how abortion is legal there. But at the same time, there's a lot of accountability work to be done. How much does Medicaid reimburse for abortion? If it does, is it actually medically or financially tenable for clinics to provide the services? In a lot of states, it's not. What role do anti-abortion centers, and also called crisis pregnancy centers, play in your states? Are they getting state funding, which is the case in blue states and red states? And let's say you are a state like Maine, for instance, which recently eliminated gestational limits on abortion. So now in theory, abortion is legal throughout pregnancy in the state. Are doctors actually providing it? Are they trained in doing it? Do they feel safe? Is there cultural stigma or social stigma? Are they concerned about getting a landlord to rent them property because the landlord is afraid of harassment? All of those are really interesting, complex details that I think merit reporting if we are curious about what it means to live in any state in this country and seek reproductive health care in generally, but also abortion specifically.
Thank you, Shefali. And let me just ask you to expand on all this a little more and ask you, how might a Trump-Vance administration seek to further restrict abortion access at the federal level, even without passing any new legislation? And would blue states be immune to those regulatory actions as they are in the case of abortion?
The one that we hear about a lot, and that I'm sure many people listening to this webinar have heard a lot about, is the Comstock Act, which, crash course, 1873 law. It was passed as an anti-obscenity law meant to, curtail the mailing of pornography. It was used to ban books. It was used to ban like, Walt Whitman and James Joyce and all of the, the dirty writers of the time. But it has become a very popular tool in the anti-abortion movement. It has been mentioned by Supreme Court justices who seem to think there is merit in the argument that its language around abortion and prohibiting the mailing of things meant to procure abortion could be used to justify a national ban. And we should note that the Comstock Act has not been enforced to ban abortion since Roe was decided. The DOJ under President Biden has said it does not believe the Comstock Act justifies going after abortion providers, in particular the mailing of abortion pills, which has become a very important source of access to care in the past 2 years. But a Trump-Vance administration could very possibly and arguably is likely to have a different approach because the people who are making those arguments that the Comstock Act justifies this, they are former Trump administration staffers. J.D. Vance has explicitly said that he believes that the law should be used to ban abortion. I think we would not at all be remiss to imagine and to look at everything that has been said by these candidates and consider that they will look very seriously at Comstock for reducing access to medication abortion, which makes up a majority of abortions, and that they will also consider ways in which the Department of Justice, the FDA, the Postal Service could all be leveraged because they are federal agencies and federal institutions to limit access to abortion. And that is something that will affect you no matter where you live because federal law trumps state law.
And let's just kind of flip things a little bit, and I'll ask, what kinds of changes might we anticipate if Kamala Harris were to win the presidency, not only in policy, but in her advocacy and comfort with defining herself on these issues? And what limits would she also experience given the Supreme Court decision?
That's a really good question. And it's something I've been thinking about a lot in going through her record when she was working in California, because when she came to Washington as a senator, she did make a name for herself talking about maternal mortality in particular. And she has, as vice president, been the face of abortion rights for the administration. And she has said that she would support signing a law that would codify Roe v. Wade's protections. Realistically, that's not going to happen. We do not anticipate Democrats having the votes in the Senate, let alone the House, to pass that kind of law. As Attorney General, she went after crisis pregnancy centers, anti-abortion centers. That could be something interesting to keep an eye on. She's a former prosecutor. She could look toward federal agencies like the Department of Justice, like the Food and Drug Administration, and think about ways in which they could be leveraged to go after state bans, to expand access where possible. I think it will be really worth probing what role a different DOJ might play in challenging different state laws and seeing whether they could be undercut through various federal legal theories. I don't think we know the answers to that, but those are questions that I think are worth exploring.
And speaking of the legal landscape, Maya, let me turn to you and ask you about some of the big cases before the Supreme Court this year on medication abortion bills and access to emergency care for pregnant people in Idaho. Can you walk us through how those cases played out and their impact, and perhaps some of the on-the-ground stories, maybe Shefali, you want to chime in here, that reporters might pursue, whether they're in a red state or a blue state?
Sure. And I'll try to keep this brief and not get too much in the weeds on the cases, because at the end of the day, these two most recent cases at the Supreme Court that came down this past June, they both avoided any decisions on the merits. The first case, which was FDA versus Alliance for Hippocratic Medicine, dealt with FDA regulations that had expanded access to mifepristone, a pill that is used for pregnancy terminations for both abortions, elective abortions, and miscarriage management. And then the second case, Moyle versus United States, dealt with access to abortion for pregnancy complications in emergency situations. But in both of these cases, the court just punted. It did not give us any legal answers on continued access to abortion pills and emergency abortion care. And as many commentators noted, Not coincidentally, the court was kicking the can down the road right before an election where a decision or decisions further restricting abortion access could hurt the Republican ticket. So, just briefly, the first case, which was the FDA's regulations allowing expanded access to abortion pills, especially allowing access to abortion pills through telehealth, which has been key in continued access to abortion care. In that case, the court held that the doctors who were challenging access to abortion pills, who were challenging the FDA regulations, lacked standing to bring the case. Standing is a technical requirement about who can bring a lawsuit in federal court. But one thing that was clear from the Supreme Court, is that even though these plaintiffs did not have standing, and so these plaintiffs couldn't bring this particular challenge to the FDA regulations, it was clear that a different set of plaintiffs could bring a similar challenge in the future, as long as they establish this standing requirement, which is, of course, what is being searched for right now. And what that would mean is that we could have restricted access to these abortion pills nationwide, even in blue states. And in the second case, Moyle versus United States, which was out of Idaho, the issue was whether a federal law known as EMTALA, that is the Emergency Medical Treatment and Active Labor Act, preempts or trumps a conflicting state law that bans abortion even when a patient's health is at risk, which is what Idaho's abortion ban does. Normally, federal law preempts or supersedes a conflicting state law. That is a requirement under the U.S. Constitution's Supremacy Clause. But in this Moyle decision, the court ultimately did what's known as a dig, dismissed as improvidently granted, which is a procedural move that allowed the court to avoid any decision on the merits about EMTALA, and just said, we're just going to send this back down to the lower courts, and we're going to let them work out a few more issues, and then eventually it'll wend its way back to us, probably post-election. So, I mean, the bottom line from these two decisions in June is the good news is, for now, women and pregnant people have access to abortion pills according to the FDA's current regulations in blue states and even in red states through things like shield laws and organizations like Plan C that will mail pills for self-managed abortion. And for now, based on the Moyle decision, patients in Idaho are for now entitled to EMTALA's protections for emergency abortion care. But I should note that that does not apply in Texas. Texas patients don't have access to emergency abortion care because the lower court there ruled a different way, and we don't have a final decision from the Supreme Court. So the bad news from both of these cases is that they most certainly, I think, will come back to the Supreme Court eventually. And it seems to me, reading between the lines, there are at least 5 votes to further restrict access to abortion pills, again, nationwide, and to emergency abortion care. And I just can't emphasize enough, based on what Shefali was talking about earlier, that if there's a Trump-Vance administration, I mean, the FDA case might not even matter because the administration could just change the regulations. And so you don't need a Trump-Vance administration to pass a new federal law banning abortion. The administration has the power, if it takes over, to change the FDA regulations or to enforce the Comstock Act and effectively enact a nationwide ban on access to abortion care without passing any new laws.
And Maya, just to clarify one aspect of this, even if Harris were to win the presidency, it seems, if I'm understanding correctly, that these Supreme Court decisions could, as they come back to the higher court, lead to these really severe restrictions, and there wouldn't really be anything Harris could do about it. Is that right?
That is correct. So even if we had a Harris administration and the FDA regulations remain the same, which is now allowing, telehealth for abortion pills, this case could go back to the Supreme Court and they could strike down those FDA regulations, which was what was sought in this case. So it's also not a safe bet of having nationwide broader access to mifepristone either under a Harris administration, because then you have to deal with the U.S. Supreme Court and its decisions.
So it seems like we're in this kind of moment of incredible limbo with this very consequential time. And so Shefali and Eleanor, what do you advise people? It's hard to write about uncertainty, right? So how are you handling that? And what are your suggestions for the journalists listening in?
Yeah, I mean, I think that was sort of the experience of a lot of journalists in who cover abortion or who cover it in states where abortion was going to be banned. I mean, in like the lead up to the Dobbs decision, where it was like, pretty sure I know how this is going to go, but you're just writing a lot of stories that are like, if abortion were to be banned, here's what could potentially happen. And like those stories bore out. I don't think there was any like, you know, you don't want to sort of fearmonger or, you know, and one thing we discuss a lot is like, I remember this after the leak of the Dobbs decision, you know, there were so many headlines that made it seem like abortion was banned. And it's like, oh no, abortion remains exactly what it was, you know, just this decision is not official. This decision, like you can do a lot of harm by making people think like abortion clinics must be closed, abortion clinics must be you know, inaccessible to me, just because of these headlines. So I do think finding ways to write about what the implications would be of different presidential outcomes for your state and your community without sort of inadvertently alarming people or making people think that the status has changed is like the needle people want to thread there.
I think that's absolutely right. One thing I will add that I have found pretty interesting to write about as well is how are people who are not journalists responding to the uncertainty? And that can be healthcare providers, it can be patients who are seeking healthcare. Like, if we are living in a moment where you think abortion may soon be restricted, but it is not yet, or you think your law is about to change, or you know it's about to change, how do you prepare for that? How do you, if you are a telehealth provider, try and provide care, market your services while knowing that in a few months to a year, you could be made illegal? How do you provide care to patients in, let's say you were in Iowa right before the 6-week ban took effect? What did it look like to be caring for patients knowing that in a few weeks or in a few days, this would no longer be legal? And how were you triaging, talking to patients? What did it mean if someone called you and you knew that if you saw them 2 days, in 2 days, they would be within the limit at the time, but if you saw them in 4 days, they wouldn't be? And were you sending people out of state? Were people making different contingency plans? And I think what I have found to be so fascinating is that the patchwork of laws and the constant change around abortion legality has really had very consequential implications for people who are just trying to get abortions and trying to get healthcare, because they are now tasked with trying to be on top of laws not only in their home state, but in a vast network of states nowhere near them. And that's a very tall order, and it changes how people live. And I think that's a really profound story we can't keep telling enough.
And, you know, this landscape, as you all have mentioned earlier in this webinar, is also broadly reshaping the practice of medicine, not just for OB-GYNs, but more broadly, and potentially also just even influencing people who are considering medical career about whether they want to become an OB-GYN. I'm guessing it's not one of the more higher paid branches of medicine. So Shefali and Maya and Eleanor, what are you seeing on the ground in terms of not just OB-GYNs, but really just medicine in general?
It's so interesting. There's a real self-segregation that's beginning in terms of where healthcare providers want to practice. And we've seen that in the data about residency applications. Not just OB-GYNs, although it is clearly happening in OB-GYNs, but healthcare professionals across the board are looking less to states with abortion bans and more to ones that don't have them. And there are two reasons for that. One is that it is not only OB-GYNs who are affected by abortion bans, it is also oncologists, it is ER doctors, it is family physicians, it is nurses, it is people who touch so many aspects of healthcare that are affected by pregnancy. The other thing that I think is really important is that the majority of new physicians are women, and very often they are of reproductive age, and they are, in some cases, thinking about if they want to have children. And when you think about that, there is a consideration about, do I want to move somewhere where I will have fewer options or will I have more? And that is changing the decisions people make. And we have seen that bear out in Texas, which I know Eleanor has reported on. We've seen that play out in Idaho, in many other states. And I've talked to a lot of doctors who are deeply concerned that this will exacerbate pre-existing shortages of OB-GYNs, of primary care doctors, of other really essential physicians who are already low paid, who are often women, and who just might at a certain point decide this is too much, not only to practice in states with bans, but to practice anywhere, given the uncertainty that surrounds providing abortion in individual states, but potentially across the country.
Yeah, I'll just, I mean, echo that and just say, I mean, you know, um, the states that have banned abortion tend to also be the states that have really poor health outcomes. Texas, you know, put abortion completely aside, right? Texas has fewer primary care physicians per capita than any other state in the country. I mean, Texas is, you know, in many ways, it's like health centers are like meccas, right? I mean, Houston and Dallas has these, you know, hospitals that are, you know, the cutting edge of everything. And also, like, most people just can't get an appointment with a primary care doctor. I mean, our rural areas are just have been eviscerated by hospital closures. We have not expanded Medicaid. We have the 20% of adults just are uninsured. One of the only times people get insurance is when they're pregnant. These are all things that have absolutely nothing to do with abortion, right? And also, they hugely impact whether doctors want to work in this state long before it becomes, you know, a political decision. You know, we were already having trouble attracting doctors because it's just harder to work in a state that where people don't have health insurance consistently, right? I mean, you're dealing with like a whole different set of challenges. And so that was already a problem, particularly in rural areas. And now, I mean, exactly as Shefali said, like, doctors have choices. I mean, we are in a pretty widespread medical workforce shortage, and doctors and nurses have a lot of choices as to where they work. And if you want to practice the full spectrum, I mean, there are OBGYNs who say, you know, I want to be able to perform abortions. That's like morally important to me. There's a lot of other doctors who say, like, I don't think that is a moral, I have no opinion on it. I do think it's part of the care I sometimes have to provide. And I don't want to be like risking my medical license and risking a prison sentence to do that. Why wouldn't I just go work somewhere else? And that's a story that I think is going to be playing out for like, to me, it's one of the most compelling conversations I have with people who don't care about abortion that much is like, if you are pregnant and you have any complication at all, right? Even if you are over the age of 40 and you're pregnant, you are almost certainly going to have to see a maternal fetal medicine specialist at some point in your pregnancy. And that has nothing to do with like abortion or anything. But if maternal fetal medicine specialists won't come work in Texas or Idaho or Louisiana because they're the people who are most commonly have to deal with these complications that lead to abortions, then like, how are you going to get the care that you need? And that, again, has nothing to do with abortion and also has everything to do with abortion.
And I wanted to just turn to the question of who is really being hit hardest by this. These are sweeping changes, so really everybody is affected. But you know, there are some regions, for example, that already had maternity care deserts or even pharmacy deserts when it comes to access to contraception. And we've seen big disparities on maternal outcomes for communities of color. And are these policies and laws enlarging these structural inequities that we already see?
The answer is yes. And two things are true about the state of abortion access. I think one is that a change like this is so big that it does not leave any part of our country untouched. And at some point, you will experience the impact of the Dobbs decision, no matter your race, your class, your gender, what have you, your geography. But there are people who are more affected than others. I was doing some reporting in Florida pretty recently looking at the impact of the 6-week abortion ban there. And I was in Miami because I had been thinking a lot about how Miami is so far south compared to, say, North Florida. And what does it mean when your closest options for care are North Carolina from Miami, which is just a crazy distance, or going to Puerto Rico, or going to Virginia or Illinois. And what I found there was that there are some people who are traveling, some people using telehealth, and a lot of people going without abortions because they are perhaps undocumented and can't travel, or they have other financial restrictions that just mean it is not practical for them to fly to another state or drive for days to get a medical appointment somewhere else. And again, it's inequality, right? There are some people who have the means and the resources and the capital, which has so many meanings, to overcome an abortion ban, and there are so many who don't. And so these inequalities that already existed around giving birth, around income, because being denied an abortion, as we know from research, keeps people in poverty. Those will only grow, and they are, in all likelihood, or the early data suggests, that's already happening.
And
Yeah, if I could just add some data points to that. I mean, we have lots of public health data on reproductive health disparities. We know in the US, approximately 75% of people who have abortions live at or near the federal poverty line. More than half of abortion patients in the US are people of color. So these bans and all their ripple effects, they have the most impact on the most marginalized groups, especially people who are low income and disproportionately people of color. And that tracks across all these different reproductive health care issues. We see similar reproductive health disparities in access to contraception, and then, of course, in access to safe childbirth and in maternal morbidity and mortality rates.
And what do we know about how far people have to travel to get an abortion and how affordable it is, not just to buy a plane ticket, but if you already have other children, which many people who are considering an abortion do, like how do you afford the childcare while you leave to go get an abortion? What do we know about that?
Dan, oh, go ahead.
Oh, no. I mean, I was just gonna say, like, yeah, I mean, we know it's like incredibly difficult. I mean, if I talk to people, I'm sure Shafali does too, talk to people who are like, I needed an abortion because I could not afford to raise another child. And like the idea that I somehow have hundreds, thousands of dollars lying around to uh, execute on that plan is sort of I mean, it's completely counterintuitive, and it's just not happening. And I think there are people, obviously, like the data shows, people are getting on airplanes, people are driving through the night, people are taking these huge trips, they're borrowing money, their, family and friends are putting up money to do this. But a lot of people aren't. And it's just like those people are having children. I mean, we have early fertility data from when Texas was under the 6-week ban. And, it takes years to sort of get the clear picture on fertility change or birth rate changes. But the early data does show, I mean, Texas's fertility rate increased like more, far beyond population growth. And it wasn't across all groups evenly, right? I mean, Hispanic women disproportionately having far more children since the this went into effect, which we do expect will sort of bear out under the near total ban. And I think really alarmingly for advocates, Texas's teen pregnancy rate ticked up for the first time in decades. I mean, no state's teen pregnancy rate. We've just been on this like steady downward decline of teen pregnancy. It's one of the like greatest public health victories in our country. And that's and this is ticking back up. And like if a low income adult cannot get themselves out of state, a low income teen absolutely cannot get themselves out of state. And so this is just not affecting everyone equally at all.
And I want to shift to just some reporting advice. And so, abortion and reproductive care are now in the national spotlight during the presidential election. And so what kind of advice and suggestions, Eleanor Trifali, might you have, and also Maya, to offer to reporters covering these issues on a local or regional level?
I think the regional piece of it is really key. I like very often love to just like pull up a picture of a map of the US and think about where all the states are clustered, where people are traveling, where flights go, and just what access looks like from state to state. I think there is a lot of reporting that can be done looking at these regional clusters, looking at clinics, looking at people, looking at crisis pregnancy centers in these states that just feel very ripe. Crisis pregnancy centers, I know I mentioned a couple of times, but they are just such a focal point for the anti-abortion movement right now. They talk about them very, very often, and they're publicly funded, and they talk about them because they seem to think with some reason behind it that they are less politically toxic than abortion bans. And I think it is smart of us to look into what they do and how much they are being funded and what care, if any, they are providing to patients. The challenge is like finding angles that feel fresh and feel new, because we've all been covering this for a couple of years now, some much longer. But I do think that by just spending more time thinking about like how regional disparities are changing from, the South to the Mid-Atlantic to the Plains to the West Coast, what have you, thinking about what access looks like on hyperlocal levels and talking a lot to the people who are trying to constantly pivot as things keep changing, whether that is clinics, whether that is abortion funds, whether that is people who just work in reproductive health and justice spaces. Like, I'm always surprised by how much there is to write about and how much more keeps coming. And I think that will just be the case even more when you have these more specific regions to focus on.
And Eleanor, do you find yourself looking a lot for data that's going to take apart sort of within the state of Texas, how one region or one community is being impacted differently, and are there data sources that you think others could use as well?
Yeah, absolutely. I mean, I will say like one of the greatest changes, I mean, I think you could say like one of the greatest losses, I won't say one of the greatest losses. A loss related to these abortion bans is the loss of data. I mean, like I've talked to researchers who are like, my entire life has been like studying abortion data in Texas, and that doesn't exist anymore, right? Like yes, okay, 5 people got abortions in Texas on average a month. That doesn't tell us, I mean, it tells us something about the reality. That does not tell us anywhere close to the whole picture, right? I mean, there are people who are self-managing abortions. There are people who are traveling out of state. There are people who are doing, crossing the border into Mexico. There are people who are doing things like, that we will never know about. And so in some ways, there's just a real loss of like insight into what is actually happening. And so much of this is becoming more shrouded in mystery. But in terms of, I think one of the things I did early on, I did a series early on about, like access to reproductive health care in East Texas, in part because when you look at the state of Texas, East Texas is surrounded on like all sides by abortion ban states, including the rest of the state of Texas. And so it's like with the region that is just like furthest from, a state where you can access abortion. The Rio Grande Valley also another place where that's extremely true. And looking at that, looking there as like, okay, this is a place that seems disproportionately harmed. It's, it's the region of the state that has the highest proportion of Black people. It has very high rates of maternal mortality, maternal deserts, all of that stuff. And it was funny when I went there to report, I thought it's a very conservative Christian area. So I expected some people would be, pleased with this, this ban, but I assumed other people would be, wanting to talk about the impact of the abortion ban. And even the people who were most outraged by it were like, but we've never had an abortion clinic here. Like we've had to travel hours to Dallas to get an abortion to begin with. Like this has never been easy for us. And so there are whole regions of this country that never sort of got the promises of what Roe v. Wade, or, never saw the promises of Roe v. Wade delivered to them. And so, we talked about stories in blue states, like, there are abortion care deserts in blue states as much as there are in red states right now, which doesn't really answer your data question. I'm sorry, but it is.
Yeah. And I just want to say we're about to open this up to questions from everybody. And I saw a couple of questions in the Q&A panel, but I want to encourage everyone to add a question or two, and we'll go through as many as we can. And meantime, I'll ask just one additional question of our wonderful panelists, which is about story ideas that you might suggest for the months to come and storylines that you see as undercovered right now.
I'll just like put in a plug for, I think Shefali spoke, gave a lot of like important information about like how to tell this from like clinics and people who are affected and all that, which I think is so important and should like be our main focus. I also think spending the time now, whether you're in a red state or a blue state, and just sort of figuring out like who are the power players on this issue on either side. Shefali mentioned, Jonathan Mitchell in Texas, Mark Lee Dixon, who's this like grassroots activist who is probably in your state. There are these players, and then your state legislature absolutely has people who are pushing on one side or the other and just trying to like pin them down now on, do you commit to a shield? Would you fight if the Trump administration said they'd do something, would you challenge that? Like just trying to sort of get as much of that on the record now before things go haywire, potentially haywire, would be a valuable use of time.
I would, as a health thought person, I would love to see more stories on the public health impacts of abortion bans, sort of in the non-emergency context. Obviously, there's high drama when you have cases like Kate Cox and Amanda Zarowski and people being helicopter out of Idaho. But there's a lot more sort of everyday health crises that probably also wouldn't qualify as an emergency under EMTALA, so wouldn't even come into the umbrella of those cases. The sort of chronic illnesses where pregnancy is still a health risk. There's been a little bit of reporting on, the impact of abortion bans on rheumatology. Female patients can't access their rheumatology drugs because those drugs can negatively impact a pregnancy. But there's a lot more. I mean, just diabetes and obesity, and especially mental health. The Moyle case, the case about the emergency access to abortion care, really dismissed mental health as even a health concern. But of course, we know that pregnancy can exacerbate or cause serious chronic mental health conditions and cause postpartum depression, etc. I think stories focusing on all those kinds of health impacts, I think would both tell the broader health story, but I think would also help to destigmatize abortion. I think that is something journalists could really contribute to in your storytelling. One fear about emphasizing the emergency cases is that it doesn't destigmatize abortion more broadly. It's like when most of the stories are upper middle class women with these very serious emergencies, people can say, well, that's the exceptional case. And that is kind of the exceptional case. And so I think telling stories beyond those cases can also help to destigmatize abortion much more broadly than just the emergency situation as well.
One thing I'll add there, I think all of these are really great story ideas that I'm going to be thinking about as well. But we also don't talk enough, I think, about the point that Maya made earlier, which is people who get abortions are typically already parents. They are typically getting abortions, perhaps for medical reasons, but more often for economic reasons. I can't afford one more child. I already have it. I'm barely making ends meet as it is. The patients we're talking about in these cases are more often low income. They are more often women of color. And I think we, in some cases, do our readers a disservice by not highlighting them. And there's a lot of reasons why that could be. There is less drama. I think we can talk about diversity in media as a factor at play because people may not see themselves as much in these cases, but they're really important. And they help us understand how the story of abortion can be a story of parenthood, of family, of autonomy, and of economics. And finding stories about that and about the more sort of ubiquitous, mundane reasons people seek abortion, I think will be really valuable in helping people understand both what this is and what it means to lose access.
Thank you. We have a question from Riley Cole who says, how do you recommend navigating conversations as a local health department in a red pro-life state? This could include Board of Health position statements, social media, et cetera. Oh, I'm guessing from a non-journalist, so I'm not sure if you all feel qualified, but feel free to weigh in. And I think also we would be very interested in Eleanor and Shefali's thoughts on how do you navigate getting everybody to talk to you on both sides of the equation here.
I don't feel qualified to speak on how a health authority should communicate, other than to say you should always respond to media requests with all the information that they ask for so fast. But beyond that, I mean, I think, I have found, I moved to Texas not long after SB8, the 6-week ban, went into effect, and I was prepared for just stonewalling from everyone. And there was some of that, but I've been really surprised by how relatively easy it is to get people on both sides of this issue to talk. I think in large part because it is suddenly so in the news. I had this experience covering abortion 10 years ago was an entirely different thing, right? I mean, just getting people to talk about abortion was even the, not all, but many of the abortion groups were more like, let's just like keep a lid on this. So I think it is much more destigmatized in both directions now. And I find that in Texas, at least, the anti-abortion groups and anti-abortion legislators and anti-abortion advocates are really eager to talk. I mean, they're really proud of what they've done. They're really proud of what they've accomplished. They are, in their minds and by many metrics, winning. And so they're happy to talk to the media. You know, take that, with, all of that, same way you do with any source. Obviously they have an agenda. The other side has an agenda. And I think, I think you just build trust by doing like stories and doing sort of consistent, and a big part of building trust, I think, is not only doing abortion stories when big abortion news happens, and not only doing abortion stories when you could be doing maternal health stories or, telling the broader story.
Yeah, exactly that. Just you keep doing it. You do a lot of stories, you are comprehensive and you are fair, and you pick up the phone. And I am always surprised that everyone wants to talk, and it's because I think they understand that if you are going to listen to them, then like it's in their best interest. It's far easier to get people to talk about this than I think it is about other things. And I don't know why that is, but Eleanor might be right that it's just like, if you're winning, why wouldn't you?
We have a question from Victoria Rossi, who says, in this landscape of increased criminalization and legal risk, there seems to be a lot more reluctance on the part of reproductive justice groups to connect reporters with the people directly impacted by these bans. How do you as reporters recommend navigating these concerns? How hard do you push for access to people seeking abortions? How do you find these sources? And do you push to use people's full names on publication?
I have a lot of thoughts about this. It's because it's something that comes up a lot, and like I think there are a lot of journalists who do this very well. Eleanor being one of them, but like especially in today's day and age, people don't owe us their stories. They have so many other ways to talk about abortions or to not talk about abortions, and so I think it is really incumbent upon us to earn the trust of people whose stories we tell, especially when they are vulnerable. And people seeking abortions in states with bans are incredibly vulnerable. They are legally vulnerable, politically vulnerable, socially vulnerable, financially vulnerable. And so I think you treat it differently than you would someone who is in power, who is a lawmaker or an authority figure. I work at a newsroom that happens to be very understanding that people who share their abortion stories do not need to have their full names in the newspaper. We very often will do only a first name. We will do a pseudonym if that is the preferred thing. Because so often when people are sharing their stories about abortion, what they say is, I've never told anyone about this before. My parents don't know. My family doesn't know. And their sharing what happened to them shouldn't be a reason for them to have to violate that, is my view. Just the stigma is so great around abortion. And I understand why a lot of groups don't want to connect reporters to people who have been affected by bans, because there is an inherent transactional element to doing journalism, because we are taking their stories and putting them out there. And so part of it goes back to what Eleanor talked about, right? Building trust and being there and doing a lot of interviews day in, day out, so that people understand that you are not just jumping in and jumping out, that this is something that you take very seriously. I also would say, like, every group has their agenda. I do not only go to advocacy groups to ask for patients. I talk to doctors, I go to clinics, I talk to other healthcare providers, and I go through social media posts and things like that. And you'd be surprised by how many other ways there are to find people seeking abortions. And some of them will be comfortable putting their full names. A lot of them won't be. And I think their stories are all quite valid.
And Shefali, when you said you go through social media, could you be more specific? And also just want to clarify from the standpoint of journalistic standards that when you're using a pseudonym, I assume you're explaining to your readers that it is a pseudonym.
Yes, I explain it as a pseudonym, or that I'm not publishing their last name because of the stigma around abortion, or X reason for seeking an abortion, or Y reason. But and I explain to sources that for readers to trust us, we need to give a reason why we are not publishing your name. And as long as you can give me one that my editors find compelling, which usually this is enough, that it will work, and that is never a problem. But social media, I mean, there's a ton of places people talk about abortion on the internet. They talk about abortion on Facebook, on TikTok, on Twitter, on Reddit. I haven't, ever tried the I don't know, something awful, but I'm sure they talk about it there too. So there's a lot of places where if you spend time looking through internet communities and are just like passively familiar with how to use social media, you will find people who have posted about their experiences and might talk to you.
And Eleanor, what sorts of things are you doing? And I'll also add that both of you are covering this as a beat, whereas many of the folks sitting in don't have that luxury. So they don't necessarily have the track record that people could turn to, where you can't necessarily say, oh, look at my coverage, you'll see what I'm like. So if you have, Eleanor, also a suggestion for somebody, just in terms of those interpersonal interactions that could be helpful.
Yeah, I mean, I will say, like, this is the hardest part of the job, right? Like, the work is, it's not work to get advocacy groups on either side to talk to you, right? It's not work to, like, find a story about abortion these days, right? Like, the work is getting people to share their, like, most vulnerable stories with you. And it's not, there's no, like, magic wand you can wave to make that easy. And I think that sometimes I've been there myself. Like, you feel like these advocacy groups have people, like, just like that could be the magic wand I could wave, and then they could give me someone, and then I could get my editor off my back. And I think, again, 5-7 years ago, maybe. And now, I mean, those groups are extremely wary. They're extremely, I mean, every time you as a reporter think like, I just need someone who can, like, exemplify this story, there's 30 other reporters, in your state who feel that way too, who are also calling that advocacy group being like, could I just have a woman? Could you just, like, give me a woman? And, like, you're probably handling it with the correct amount of, like, import and grace and humility. That doesn't mean every reporter is. So, like, you're sort of, like, working against the reputation of reporters who have called with, like, who have not treated that woman's story, or any woman's story or any person's story with, like, the dignity that it deserves. So I think I really understand why groups are hesitant to work with reporters they don't have a relationship with. And it is hard if that's not your beat. I mean, I think the truth is, like, the case you should be making is, I mean, you build a relationship with those advocacy groups, but particularly as a beat, if this isn't your beat, the case you really have to make is to, like, your editor, which is like, I'm not going to likely get us a story that features a woman who had to travel out of state, under the cover of darkness, if I don't have time to work on other stories on this beat. Like, we're not, like, when President Trump, does something and you're going to want, like, an enterprise story about how this affects people in my state, like, I'm not going to be able to write that story with, like, a compelling human lead if I haven't done the work before then to start covering this issue, not every day, not, like, as your full-time job, but to, like, write about these issues so that you can say, hey, remember 6 months ago when we talked about that story I was doing about maternal mortality, like, wanted to circle back, like, are you hearing of anyone, anything like that. So yeah, I mean, it's just not an easy time. Everyone is sort of, like, caught in the crossfire on this one a little bit. And I have a lot of sympathy for these groups that are getting calls from everyone saying, could you ask your client who's in a really, perilous situation if they'd be willing to, like, talk to a reporter. The key is, like, what you want is that when someone is there saying, like, God, this is the most outrageous thing. I can't believe more people don't know about this. I'm so mad about, like, how my case is being handled. Like, more people should know about this, that the advocate will say, like, if you're interested in talking to a reporter, I know someone I could connect you with. And that's, like, sort of, I think, what you're building towards, that you're, like, the name that comes to mind.
Just switch gears a little bit and ask about this idea of how the focus on abortion is maybe sucking the oxygen out of the room about all these other reproductive health care issues that, Maya alluded to, for example. And one of the people on the webinar, Mercedes Cannon Tran, asks, is it worth looking even in blue states at regional hospitals and facilities and trying to understand what's happening just reproductive health care more broadly, pre and post the Supreme Court decision?
Like, yes, absolutely. I was reminding myself yesterday about there's a senator from Michigan, Gary Peters, was the first senator to tell his abortion story. It was some years ago, and the story he told was about his wife, also in Michigan, having a pregnancy-related emergency, needing an abortion and not being able to get one. And it was because the hospital they went to didn't provide abortions. And so they had to go to another hospital and pull some strings to get in and get seen and get life-saving care. That's in Michigan, a state that did not have an abortion ban, that does not have an abortion ban, and that now, post-Dobbs, has a right to an abortion. And so, like, I bring that story up because it highlights that there were barriers to accessing comprehensive reproductive health care and pregnancy-related health care, including abortion, but not exclusive to abortion, in many states. We can look at hospital consolidation, we can look at the rise of Catholic hospitals as part of the story as to why. But what that tells us is that this is not unique to red states or states with abortion bans. And I would be very curious to hear what reporters find about what has changed before and after Dobbs, because some states have tried to become more permissive around abortion and more supportive of it because of the politics. But has that borne out in practice to improving healthcare access and outcomes is a story we don't have and we don't know the answer to.
I just want to add, I think that whole conscience clause, right? The quote unquote conscience protection for sectarian hospitals, Catholic hospitals, I think have been reported on a lot. After these recent decisions, one of the issues that came up in both the FDA case and the emergency abortion case, so in both the FDA versus Alliance for Hippocratic Medicine and Moyle versus US, was a sort of supercharged conscience protection that even with a law like EMTALA that says everybody gets access to healthcare in emergency, people can raise a conscience objection to providing abortion care, even in emergency, which means even in blue states, even in the most liberal states, Catholic hospitals, other sectarian hospitals, or individual providers who say, I have a conscientious objection to providing abortion care, even when a patient's health is at risk, they have protection. They can do that. And so I think that is going to get worse over time, given things that were mentioned in these recent cases. So I think understanding what's happening on the ground with regard to that situation, even in blue states, would be really important going forward.
Thank you. And Eleanor and Shefali, I'm wondering, how do you both approach building sources on this beat and ensuring balance in who's talking to you without letting their agenda dictate the conversation? And I'll also throw in an idea when I say sources of not just people, but also data. And so, are you using census data? Can you use other sources to get at these questions of, or, are there folks that you think are producing really good data that will help you to say who are the folks in your community or in your state who are seeking an abortion? To go back to this point about most of them are women with children and so on. Like, how do you ground the situation at a more local level too?
Yeah, I mean, I think I'll say there have been several really impressive and important data projects that have been running since the Dobbs decision. We Count is a big one of that's like tracks sort of like the most conclusive data tracking we have of abortions, and which has shown that the number of abortions performed in the United States has actually increased since before Dobbs. Although obviously it's not universal across the whole country anymore. I mean, I think that's a big piece of it. There's a lot of Texas is like sort of because we had this period before the Dobbs decision where abortion was banned after about 6 weeks of pregnancy. We are starting to see like more data come out in Texas that I assume is being replicated in other states now post Dobbs, around birth rate increases, infant mortality increases, maternal mortality increases. And again, things that are not necessarily actually about abortion, and yet we will have to like read into the time period, what can be sort of interpreted about before and after these bans. But yeah, I mean, I think that's a big part of like grounding your reporting is just like, I mean, it's like on any issue, like you don't let the advocates sort of like run away with you. Like we are just like, our job is a little bit of like the clearinghouse of like everyone. I mean, everyone on, and this is true on a lot of issues. I do think abortion really attracts like yappers. I mean, everybody just wants to talk all the time. And you're like, okay, this is on all sides. They're just chatty folks. So like that's you're just like taking it all in. And then I mean, our job is to, report out the facts. And that's obviously not always super clear cut. But I do think you know, a lot is happening, and it's sort of our job to be like just like the what's the sort of cliche, like the drafters of history, right? Like we're just sort of writing it as it's happening right now, and like we'll figure out years from now like sort of what it all meant. But for right now, we're just like, there's a lot happening and we should have to like tell it.
And do you, Shefali, have any suggestions on sourcing and also just databases that you're tracking, but also, orgs that you find particularly useful?
I'm glad that Eleanor mentioned WeCount. Their data is great. They're from the Society for Family Planning, and their directors, they're both university professors, one in Ohio, one in San Francisco. They're great. They're worth reaching out to and talking to if you ever have questions about understanding what's happening on a macro level in abortion access. Guttmacher, which I know has been mentioned in the chat, has a lot of great resources. They are quite accessible. Everyone who works there, very smart, very helpful. They're an advocacy group, but Center for Reproductive Rights does have very good tracking and very comprehensive knowledge and can be useful for just getting a sense for what's going on. I find that on the anti-abortion side, SBA Pro-Life America usually has pretty interesting tracking, priority bills and states they're looking at, trends they're monitoring, that I find very valuable to learn where influential groups in the anti-abortion movement are focusing their energies. We talked about crisis pregnancy centers. There's a map called the Crisis Pregnancy Center Map that's done out of the University of Georgia that is really helpful for those who are interested in that specifically. And I know we mentioned KFF. They're great. And then I'll just shout out, the obvious ones, the census, the CDC, all the big public health federal or institutions that are really valuable. Oh yes, big fan also of, just people at UCSF are really smart. They know what they're doing. They have a lot of really valuable data and great experts to talk to if you're a reporter.
And in our pre-call, we talked about where people are going to get an abortion and who's tracking that. Do you mind to just reference some of that too for our audience?
Yeah, I know we did talk, you mentioned earlier in the chat, the New York Times analysis, that was very helpful. WeCount does do some very good analysis of where states have seen surges, which is often a proxy for looking at data. Some states like Florida also do track in-state versus out-of-state patients. And so you can see, for instance, 84,000 abortions in Florida last year. This many were from people who are out of state, and this is how that compares from year to year. KFF has for a long time been doing what percentage of people in states with abortions were from that state versus not, which is how we knew that even before the Dobbs decision, half of all abortions in Kansas were for people from out of state, which is like sounds crazy. And then you remember that Missouri is right there. And I'm trying to think through what are some of the other really valuable ones. I think 538 had a pretty robust project. Oh, Middlebury. The Middlebury abortion map. That's the one I'm forgetting. But they do really incredible research. Basically, I think the professor has like an army of undergrads who can do surveying for her constantly. And they're always finding out what are the wait times at abortion clinics, which is a helpful proxy for how many people are traveling there and how besieged is the reproductive healthcare network.
And I'm going to close with just one last question. And that is, anti-abortion advocates are currently trying to use the courts to block ballot measures in states such as Arizona, Arkansas, Florida, and Montana. And what do you all see at stake here? And what are anti-abortion groups so worried about when it comes to these ballot measures going before voters?
Abortion is really popular. Abortion ballot measures keep winning, and that is a concern to abortion opponents. They haven't figured out a winning strategy yet, and trying to change the conversation, like in Florida, where they've added this new budget language is one approach they're trying. We saw in Ohio, they tried to raise the approval threshold to 60%, and that failed. But it's increasingly an argument for them that the best way to stop abortion from winning at the ballot is to stop people from voting on it. It's also, I think, ballot measures are interesting because they're a proxy of where people are, and they can have real implications for people's lives. But they are not universal, and a lot of states with abortion bans don't have a ballot measure process, which is something that, like Texas, something that we should talk about as we think about the future of the abortion rights movement.
I think one thing that's been interesting about the ballot measures is their popularity has been surprising, at least in some states, right? Some deep red states, abortion ballot initiatives, like abortion rights ballot initiatives, have won. And at least one theory is that when it's just on a ballot initiative separated from a party ticket, it's easier for people to say, well, I'm a Republican, but I support abortion rights, so I'm going to vote for this. So I think it's less clear what will happen, say, in the general election and how much abortion will move the needle there, where people are voting on a broader party ticket. Like, the nice thing about the states that allow for these ballot measures is you can just focus on abortion, and people can vote about how they feel about that issue. And what we see is over and over in the deepest red states, people support access to abortion care.
Right. And just like, I mean, in the same election or same election season where, Kansas and Kentucky and all these states like really came out and surprised people with these, wins for abortion, Texas reelected all of its, Republican leadership. And that's not because Texans on surveys say that they support the abortion laws. It's just that, abortion, as amped up as many people are about abortion compared to in the past, it's still on a day-to-day basis, like voters say, like, it's not as important to them as, say, like inflation or immigration or the economy, or like things that they're like, well, maybe I care about that, but like, I also care about, the price of eggs or whatever. So it is like, if you're voting yes, no on abortion, you see a really different situation than on candidates. But as Shefali mentioned, some states, including Texas, don't really have a meaningful way of getting that measure on the ballot. So it's not a universal overturning mechanism.
Well, I just want to thank all of you. This has been such a educational and helpful and inspiring conversation. And I also want to thank the audience for their participation and their great questions. I want to thank Ryan White, our content editor, and Abs Mandarbishu, our communication strategist, for all their work behind the scenes on putting this webinar together. We'll be emailing you a survey asking for your feedback on today's program and for your ideas on other topics of interest. Please take a moment to complete it. And we also urge you to help support these webinars. You can find more information here on how to do that. Thank you so much. We'll be archiving this webinar a little later today at centerforhealthjournalism.org. Thanks for joining us, and have a wonderful day.